Hi, this is Brian Kim. I want to share with you this case of a patient who was referred to me. This patient had a dislocated artisan, or otherwise known as a Verisyse iris claw phakic IOL. This patient had a superior claw that was de-inclavated and touching and bouncing off the corneal endothelium, causing localized corneal edema. And so the patient was referred to me for further evaluation and treatment. I had a long discussion with the patient about explantation, but then maybe needing corneal transplantation as well as cataract surgery in the future. So this is the patient's left eye. On the right side there, you can see that the cornea is a little bit edematous, and it's hard to appreciate, but right there is the de-enclavation. The iris claw is not attached to the iris, and it's actually touching the cornea, causing localized corneal edema and decreased vision. So the plan is to remove this lens, and I think the best approach is to make a large scleral incision. These lenses are made of PMMA. PMMA lenses are very strong and you cannot cut them or bend them. And so when they're inserted at the original time of surgery, the incision has to be a large 6mm incision. So similarly, we're going to make a large incision to explant this lens. So I'm first doing peritomy. And then using some cautery. And then I'm gonna make a scleral groove. No different if you're going to do an extra cataract surgery. And you want to make the groove deep enough that you get a nice deep plane so that you can tunnel. You don't want to make too deep of a tunnel, which you enter too early, like you would do with an extra cap. You don't want to make a shallow groove as well, because when you tunnel, you'll just buttonhole and make a superficial incision. You can see I'm wiggling the crescent blade in order to advance the blade. Of course, in the US, we don't do a whole lot of extra caps or M6 cases, and so this is a little bit less natural for us. But as long as you follow principles of staying deep in the groove, making sure you're parallel to the sclera, and you wiggle very gently, and you have a nice sharp blade, you should be able to do this case. Even though it might take you a little bit more time, you should be able to do this case fairly easily. So I'm just trying to extend the scleral groove there. And then I'll make my paracentesis incisions first on the right side and then the left side. I'm injecting intracameral lidocaine. You can see the lens is kind of dancing, and that just shows it's not attached to the iris on that right side there. I'm injecting some dispersive viscoelastic, and then I'm going to make an incision with my 2.6mm blade here. I was thinking about extending it, and then I decided I'm not going to extend it because I don't want the chamber to collapse. So through that incision, I'm going to go ahead and use micrograspers. These are 23 gauge MST micrograspers. I'm going to grab the lens, and you want to get a really nice bite. And so you can see how big of a bite I'm taking with those forceps. That means I have excellent control of the lens and it won't slip out from my grasp. And this is just a cannula. This is the BSS cannula. And I'm going to push down with the cannula on the iris that's held by the claw, and it comes right out. And so now I'm going to widen the incision. Again, I had a small incision because I didn't want everything to start to collapse, viscoelastic start to come out. So through that smaller incision, I was able to do my maneuvers, keep a nice chamber. And now that I've disinserted the iris claw from the iris, I'm able to widen the incision with my diamond blade here. And then I'm going to inject some more viscoelastic to push that lens away from the cornea. And these are the microforceps. I'm just going to grab the optic haptic junction, rotate my wrist, and turn the lens 90 degrees counterclockwise, and it pops right out. At this point, I'm going to do the cumbersome and tedious but necessary job of suturing the incision closed now. The eye is full of viscoelastic. I'm doing a 10x speed here of closing the incision with 10-0 nylon sutures in interrupted fashion. I'm going to put around 4 of them here. And after I place these sutures, I'll go ahead and bury the knots. Since the eye is full of viscoelastic, I like to make some nice tight sutures here. I bury the knots, and in between the sutures, I place my mechanical INA. I start to irrigate all the viscoelastic from the anterior chamber. You can see this patient is very highly myopic. You can see how deep the iris is. You see some pupillary movement with the irrigation fluid. And then with 10x speed, I'm going to close the conjunctiva with 2 interrupted sutures with the nylon here, and I'll take them out in a few weeks. So this is the end of the case. The patient did quite well. I waited several months for that corneal edema to clear up. Unfortunately, the corneal edema did not improve, and so the patient underwent a combined phaco with a triple DSEC, but the patient also had astigmatism, so we did a triple toric DSEC on this patient, and I'll be sharing that case in a future video. So I hope this was helpful to you, and I thank you for your attention.